So at this year's ASH, we are presenting the long-term outcome of our study, which is to use this novel combination of lenalidomide, a pill, and also rituximab, which is anti-CD20 antibody, to treat as initial treatment for patients with mantle cell lymphoma. And as we reported in 2015 for the interim report, that combination has very high response rates. The overall response rate was over 90% and complete remission was over 60%. And it would be nice to see if those responses are durable. So at this year's ASH, we are pleased and able to present those long-term outcomes. So it does seems to be the case. At 4-year mark, 70% of the patient continue to stay in durable remission, and 83% of the patient are alive and doing well. Additional to response duration, we also reported safety, long-term data, which is also very important. We did not see any new safety signal. As we reported earlier, the treatment is generally well tolerated, and certainly we see cytopenias, which is reduced blood counts. They were generally asymptomatic. Things like febrile neutropenia, they were very rare. We also observed constitutional symptoms and inflammatory symptoms at the very early stage of induction. Those were generally reducing frequency and severity as time goes by. Patient would normally receive induction phase, which lasts for 12 cycles, and this is followed by maintenance treatment, which would be ongoing. Patient also have option to stop treatment after 3 years on study.
Okay. So I was reading through some of the adverse events that came up around the 3-4 year mark, including the infections that came along. Any thought of that it might have been attributable to the low blood cell count?
And I think it's a very fair question. Common infections are being very closely tabulated on the study, and they generally comprise of upper respiratory, urinary tract infections, sinusitis, and skin infections, and which you may expect to see patient, in this patient population. They are on a form of immunosuppressive therapy with anti-CD20 and also lenalidomide. I think those are things that we should maintain vigilance. However, all of those are easily managed in outpatient clinic settings, and we really would need to get patients into the hospital and getting IV antibiotics. I think it's more so because of immune suppressed regimen. The blood counts, I would say, all the treatment would have a threshold for a patient to restart their oral medications. So generally speaking, I don't think our patient would be on a very prolonged period of low blood counts, in particular neutropenia.
Okay. And the incidence of secondary malignancies, would you see those as more than you'd expect in this patient population?
Also a very good and fair question. So we report, secondary malignancy very diligently, and the majority of the case, in our case, there were only 6 subjects that reported secondary malignancy. 4 of them are skin-based, so limited squamous cell or basal cell, and they were resected and patients were maintained on the treatment. I do want to point out that the study did not preclude patients with prior history of skin cancer to enroll as long as they did not have any active evidence of disease at the time of enrollment. So our reporting is anything, any occurrence, without respect to whether they were related to treatment or not. On the other hand, patients with a diagnosis of lymphoma and also on chronic immunosuppressive therapy, they are at a high risk of developing those skin malignancies. Now, I do want to report that there were 2 cases of systemic secondary malignancy that was reported. One was with pancreatic cancer and the other Merkel cell cancer. Both occurred in patients with advanced age. Certainly, we would advocate for very close and vigilance while patients receiving those chronic therapy, especially with biologics.
Okay. And when it comes to going beyond this patient group, you've said it's the 5-year follow-up, are there any observations or ongoing trials for larger populations or at different age points?
We sincerely hope that with this long-term data, which validates the efficacy but also provide additional information on the safety, we would inspire enough interest and also momentum for a larger study to take place, preferably in multi-center or intergroup global study to look at this particular combination and possibly compare that with other conventional combinations. Another possibility is, as you know, there are new advances in novel therapies with other agents, so new combination is another promising direction and strategy that one should consider, at least to explore in pilot setting. So we're very excited to be part of this ongoing efforts to try to bring new treatment to our patients. One would provide higher treatment efficacy, effectiveness, at the same time hoping to provide that in a very patient-friendly environment, outpatient settings, in order to preserve quality of life.
And if you had to give a summary statement, a take-home message for any clinicians watching this, what would it be?
That novel treatment for mantle cell lymphoma is on the horizon. That includes using new combinations that are chemotherapy-free as initial therapy, and our early efforts or pilot study has shown that these efforts can be active and relatively safe at the same time. However, we hope that more efforts for larger study with a broad population should be ongoing to test our hypothesis and bring those possibility closer to reality for our patients.